Hello, my name's Jerry Nolan. I'm a consultant in intensive care in Bath, the United Kingdom. It's a pleasure to talk to you about intraosseous versus intravenous access for cardiac arrest. These are my conflicts of interest. I don't think there are any directly related to this other than perhaps the Paramedic 2 trial, which I will mention briefly during the presentation. This is what I want to cover in the next 12 minutes or so. So does intraosseous work? How fast is it compared with intravascular, with intravenous access? And then we'll look at observational data and then some data from Paramedic 2 and the ALPS trials. So the intramedullary canal is a highly vascular structure. And we're showing here the head of the humerus. And we can see from this very brief video, injection of contrast intraosseous through the head of the humerus there, at least when somebody has got a spontaneous circulation, clearly from looking at that contrast, will result in reasonably rapid delivery to the central circulation. Of course, there are a number of sites that can be used. I think by far still the most popular is the proximal tibial site, as you can see here, but the proximal humeral site is favoured by some, and as you'll see from some data I show you, may actually result in slightly faster access into the circulation. These are animal data. It involves the injection of 1 milligram of adrenaline or epinephrine into pigs who have been put in cardiac arrest secondary to hemorrhagic shock. So it's a slightly different model from perhaps standard cardiac arrest, but it gives us an idea of speed of access and the concentrations achieved when we compare in the gold band here the intravenous or peripheral intravenous route, and then sternal intraosseous is in green, and then we have the humeral intraosseous in red. And then down here, blue is tracheal, and finally the purple one here is the tibial route. And in fact, those two, the tracheal route and the tibial route, both achieve significantly less concentration than the gold IV one. So I think they're useful animal data, although it's difficult to know how much we can extrapolate that to the human scenario. One of the very few randomized controlled trials that we have on this topic is this one in out-of-hospital cardiac arrest comparing humeral IO with tibial IO and peripheral IV. And I think the important point to point out here is that the initial success rate with tibial IO is substantially more than peripheral and more so with humeral. And particularly when you take into account the displacement rates, which are higher with the humeral IO route, it leaves us, if you look at this central set of data here, with tibial IO, at least in terms of speed and success of getting vascular access, is probably the best. There are several observational studies out there. I'll summarize them in a minute, but I just want to show you the most recent and probably the largest of these, and this comes from the Resuscitation Outcomes Consortium, looking at cardiac cause of cardiac arrest, and it's looking at whether adrenaline was administered IV or IO, so actually given, and they've excluded those where both routes were used. And this was mainly using the tibial IO route, as I've already mentioned. That's by far the commonest route to use. Huge numbers here, obviously far more using peripheral intravenous than is using intraosseous, as you can see. But what is really important is the differences in the baseline characteristics of these groups here. So there are more women in the IO group, more bystander witnessed in IV. There is more bystander in this particular series, more bystander in the IO group. Public location is more common in IV, and very importantly, there's a far greater proportion with initial shockable rhythm in the IV group. So clearly, if you do a direct comparison of outcomes between those two, it's going to favour IV because of those characteristics. And that's just a summary of the key differences. And we'll see that again coming up with other studies. If you look at the unadjusted data from this observational trial, not surprisingly, survival to hospital discharge here in the centre is almost twice that for the IV group than the IO group. And then if you do some pretty fancy statistics using propensity matching, as you can see here, you still end up with this matched group here, just under 6,000 patients in each group, with a survival rate that's substantially higher in the IV group, with an odds ratio here for favourable neurological outcome that's almost twice as high in the IV group. And this is a systematic review that was undertaken on behalf of ILCOR, and it shows the 6 observational studies that we have so far. The one I've just shown you is at the bottom of the table there, the Zhang study, And the point about this is that there are all sorts of different sort of interventions and comparators, depending on whether you look at successful IO, whether it was an IO attempt versus IV attempt, or whether it was initially successful, either IO or IV. And very broadly, if we take the intervention arm here as being the IO group, you can see, generally speaking, in all of those studies, there is a significantly worse outcome for those in the IO group because, of course, both the characteristics don't match. And this just gives you a summary of those for ROSC, and we can see here favouring IV down here, and then for survival to hospital discharge, again favouring IV. But again, I must emphasise clearly significant confounders in those. So we have now two RCTs that we can look at, not where the intravascular route was randomised, but where in this case it was adrenaline versus placebo, a large study from the United Kingdom. And this slide is important because it makes the point that the time to delivery can make a big difference. And if we look over here under A on the left-hand side of this slide, this is looking at probability of ROSC over time, with adrenaline in the kind of pinky group up here and placebo in this arm here. Remember, this was a blinded trial. And you can see there that the probability of achieving ROSC drops, of course, as time goes on. Time to drug delivery goes on, whether that be placebo or adrenaline. And in fact, the kind of difference between the two, between the adrenaline and placebo arms, is pretty well maintained throughout. In fact, it actually, if anything, starts to widen as the time goes on. The same is true of probability of survival, as you can see here, although, of course, the dropout is quite substantially more for survival to 30 days. And in fact, the summary statistic at the bottom of that slide, you can see clearly a reduction of about 10% in terms of relative chances of 30-day survival per minute delay in giving that drug. So we've recently published this, which is an analysis of intraosseous versus IV for this Paramedic 2 trial. Now, this, of course, was a secondary analysis of the study. These were not randomized, I hasten to add, but it just goes to show you, if you look at the absolute numbers here, that more than 30% of these patients were given adrenaline via the adrenaline, or I should say placebo, via the IO route, rather. And you can see, once again, matching these observational studies, there's far more females in this group. There are more shock or rhythms in the IV group, and so forth all the way through. For this study, IO is delivered significantly longer into the cardiac arrest, and that's because paramedics were, based on their protocols, instructed to attempt IV twice, and if they then failed, they would then go to IO. So inevitably, the intraosseous route was more delayed. And the headline from this is here. So ROSC at hospital hand over here. If you look at the odds ratios, comparing adrenaline with placebo, they're absolutely identical. They're both about 4. So in other words, 4 times the chance of achieving ROSC if you get adrenaline versus placebo, whether it be the IV route, you can see here, or the IO route. For the longer term outcomes, the point estimates start to drift towards favoring adrenaline, but in none of those cases are they significantly different. And the key statistic to look down here is down this side, which is the interaction statistic there, and there's no significant difference. So we've basically shown in that trial no difference between the two routes. This is the ALPS trial. This was a trial looking at amiodarone and lidocaine versus placebo. Again, it was a blinded trial, and you can see about 1/5 of their patients received the drug through the IO route. The vast majority, as you can see from the slide there, were tibial. And interestingly, of course, the distribution of whether they got IO or IV is not the same throughout all the study sites, with about half of them contributing most to the IO access, just because of presumably paramedic preference. And the data from the ALPS trial look very, very similar. These have been published recently in Circulation, very similar to the Paramedic 2 trial, where you've got a tendency for the point estimate to favour IV at all these outcome points here, so survival, hospital admission, hospital discharge, and neurologically intact. But again, these all overlap these confidence intervals, and if you look at the interaction statistic down here, there is no significant difference. LCOR has not only undertaken a systematic review, but has also come up with these treatment recommendations. These are available in the public domain on the LCOR website. And the bottom line treatment recommendations here is that we suggest IV access compared with IO access as the first attempt. And that's based really on some of the observational data, but also on some of those 2 RCTs we've just seen where the point estimate seems to favour IV. And then here, if attempts at IV access are unsuccessful, the number of attempts are not defined, by the way, then we suggest IO access as a route for drug administration. So let's pull all that together in a summary. Is it effective? I think the answer is yes. The animal pharmacokinetic data certainly suggests sternal, although that's not used very often in humans, but definitely humoral sites are similar to IV. Tibial might be less effective in terms of drug delivery, in terms of concentration achieved, but as you've seen from the data, it may be that it's much faster, and I've taken that bullet down here, it may be much faster than IV access. The Paramedic 2 trial data would suggest that in fact, in terms of ROSC, IO is identical to IV in terms of its effectiveness. And the ALPS trial was suggested possibly that IV may be more effective, but as I say, that was not statistically significant. I think really important is that if we could show that IO was faster to achieve and therefore shortening the time to giving adrenaline, it may be proven to be beneficial. And clearly, there is without doubt the need for a randomized controlled trial. Ladies and gentlemen, thank you for your attention.